Kristen was short, I'm very short, I guess. I'm fortunate to introduce our next guest speaker, who is Edye Schwartz. She's the Director of Systems Transformation in New York State Association of Psychiatric Rehabilitation Services, otherwise known as NYAPRS. And when you guys hear acronyms all the time, this is something we use in the mental health field, NYAPRS. Edye Schwartz has a long history in the field of mental health and is a strong proponent of the recovery movement. She has worked to advance recovery-based approaches, operationalizing her training and beliefs while Director of Community Support Programs at Westchester Department of Community Mental Health, where she worked with programs to infuse recovery into service provision. From there, she became Executive Director of Putnam Family and Community Services, or PFCS. And during her 13-year tenure at PFCS, she more than doubled its staff and programs and increased its budget by more than $3 million. More importantly, PFCS flourished as an agency focused on recovery, implementing services that nurtured recipients and created an atmosphere where people could feel empowered to control the outcomes of their treatment in the course of their lives. Dr. Schwartz has shared her experiences by teaching courses at Lehman College and Hunter School of Social Work on leadership and management, recovery-based mental health services, and psychiatric rehabilitation. In addition, she has presented workshops and keynotes at various state, national, and international conferences. Dr. Schwartz has been involved with NYAPRS for many years, serving as member of the board of directors and as its president. In 2010, Dr. Schwartz joined the NYAPRS team as the Director of Systems Transformation Initiatives and provides technical assistance and training on a variety of issues, including transforming to a recovery-based service system, the impact of healthcare reform, integrating behavioral and physical health systems, and excellence in administration and management practices. We're fortunate to have Edye here with us. When we were looking at doing this conference, I kind of suggested her to Paul because I heard her speak in Albany many times, and she did a wonderful job, so let's welcome Edye.
That was longer than my talk, and I have to extend it. So I think when I go up to my room tonight, I'll be shortening that bio. But thanks to everybody for having me, and it's really a delight to be here. I'm one of those awful New Yorkers. I was born in New York City, and I live an hour north of New York now, and I go to Albany, but I don't kind of go that way at all. So I've never been out this way. It's quite delightful. It's very beautiful here, and thank you so much for having me. Appreciate it. Come on down to New York City, give me a buzz. So we're going to shift gears a little here this afternoon. We're going to talk about mental health and substance use. So we've had great presentations this morning, giving you kind of a national perspective, and I'm going to talk a little bit about how our mental health, our behavioral health system fits or doesn't fit into this system. So first, just for, how many of you know who NYAPRS is? Very few, which is really interesting. So here we are. We're an interesting group, and the reason we're so interesting is that we're a coalition of providers and peers. So we make up together a group that partner those who have a lived experience with mental health issues and those who work with people who have a lived experience with mental health issues. And that is, there are peer groups and there are provider groups, and we are a combo of the two. That's our fearless leader down there in the corner, Martin Rosenthal. Any of you who want to get every bit of up-to-date information can join up on the e-news, which he sends out 9,000 a day. Those of you who get it will understand. And when I worked for Putnam County, the commissioner there used to call me to get Harvey's info because it came out quicker than anything else comes out. So, you know, we're an interesting organization. We provide a number of different kinds of services. I do training and technical assistance, and we have a whole work component, our grassroots advocacy piece, and our peer services, where in New York City and throughout the state we provide peer-to-peer bridging services. And then we do all of that by really infusing within all of that person-centeredness and cultural competence in service delivery. So I've got a lot of pictures in this because one of my friends, Dale Jarvis, who's a great consultant, he said people fall asleep, and it's like 150 degrees in here, so I want everybody to stay awake. So, you know, look at our cute pictures, and hopefully I won't drone on. There's a lot going on. on. I think you kind of got that already, right? And it's happening really quickly. Our Commissioner of Mental Health, Mike Hogan, he made this statement, if healthcare reform is successful, there may no longer be a need for a public mental health system to handle mental health. That could be very scary to us. On the other hand, as I'm going to point out a little bit as we go along, we haven't done such a great job on the mental health side to date. And so maybe the change is not such a bad thing. And that's kind of what I want you to keep in the back of your head as we talk a little bit today. People are very anxious, they're uncertain. You know, I think Michelle, in that long bio, I was the CEO of an organization, a treatment agency in Putnam County, and I really know what it is to run an agency. I knew every staff member, I knew their families. I knew who would really be in trouble if they lost their job. I knew every issue that everybody was going through. And what happens in our system is that we become self-perpetuating. We want to take care of the staff as well as the people who access our services. And I think somewhere along the line, even though I totally understand that, we have to be cognizant of the fact that the brass ring are the services that people are accessing and their ability to recover and get a life back. And if there needs to be less of us providing those services, that's really okay. And that's just a very, very anxiety-producing thing to think about. Plus, sometimes I get tomatoes thrown at me for, but they've cleared your table, so that's good. A little brownie could go at me over here. And the last thing is, you know, what I said before, kind of what we've had, has it really been the best? We still have people who are languishing in mental health services, who receive mental health services way more than they need, and who wind up having all their friendships and lives within the mental health system and not in our community. So when we talk about integration, we're really talking about something a little different. We're not talking about services being integrated. We're talking about people having the right to have a life back in the community. Because you know what? Every single person deserves to have a friend who isn't paid to be their friend. So we have had an unprecedented rate of change. Just look at these numbers. It's so quick, it makes your head twirl. And sometimes I feel like, you know, Linda Blair in The Exorcist. Every time I turn around, there's a new change. You know, first, a pharmacy benefit was taken over by managed care. Then these regional behavioral health organizations began, and we talked a little bit about that. Now the Medicaid beneficiaries are being signed to new health home networks. We're going to talk about that. Michelle and I just got an email from Harvey this morning that phase 3, which you guys are in, the health homes have been assigned, but not your county yet. So we're still waiting to see who gets that. And then in 2014, you know, we're going to have the big full capitation, and God knows what that's going to look like. We're still waiting. And here's the backdrop of this issue. You know, when I say things haven't been so great to start with, I mean, take a look at those numbers. You have 5 million people costing $50 billion annually. You have 20% of Medicaid beneficiaries using 80% of service. And of that 20%, 40% have behavioral health diagnoses. And New York spent $800 million on avoidable readmissions. That's the most of anyone, of any of the states. 70% had behavioral health diagnoses, but I have to tell you, those readmissions are mostly medical, not psychiatric. And of course we know, everyone's been talking about it, that people with mental health diagnoses die 25 years earlier than the general population. And that is just pathetic. And a lot of that is because 85% of them are unemployed. And we're going to talk a little bit more about why people have such kinds of health issues. And part of it is that unemployment and poverty is the greatest consequence of mental illness, and probably the most devastating to physical health. So this is someone from the federal level kind of giving some information about people who have multiple chronic conditions. I hate that word, but that is the word being used. We're just saying that, again, you have a small number of people who are driving a large number of costs, and something has to be done. And that's the issue, is that, you know, if a small number of people were driving a large number of costs and everybody was getting better and integrating into life, and people were living well, and their health was good, we would not have a crisis. But because that isn't happening and the cost is high, that's what's creating the crisis for us. I think you've probably seen a number of these things before. I got my MSW in 1981. You think someone would have thought about this prior to now, but we're kind of slow to learn in the mental health field. But these are the issues that people have, and I have to tell you that we don't tend to look at them, or we didn't tend to look at them. And why do people have these issues? And as I said, part of why people have these issues are medications. Medications have weight gains. People are on tremendous cocktails of medications. People are over-medicated, and medications have side effects. Then there are people who use medications because they need to use them, and they still have side effects. I was telling people, one of the things about the heat that gets me is I have chronic Lyme disease, so I'm on like gazillions of antibiotics, and that makes me hot and, I'm woozy. So I have to take them because otherwise I'd be upstairs in my room with the air conditioner on, but I would be in bed. So I take them, but I have all these side effects that come from them. So when people take medications, any of you who take them know you're going to get the side effects with them. But these other things, smoking, eating poorly, being sedentary, doesn't that sound like people who are poor and bored? People who are unemployed, people who are depressed. My husband is a union carpenter, so he works, he doesn't work, he works, he doesn't work. You know that syndrome? I don't know if any of you know anyone in the labor fields. And I gotta tell you, when he works, that's when he does like work around the house. When he doesn't work, he's like in at the kitchen table listening to WBAI all day, and it's like, that's it, So people get depressed when they're not working, and then they get depressed, they eat. They're sedentary. People can't afford to go to the gym. People don't feel well. They don't go out. So what's happening is that these issues are creating situations for us where people with psychiatric disabilities are sick. And what's the takeaway for us? The takeaway is that for years we've provided behavioral health, not even behavioral health, mental health services, not talking to substance use, and certainly not talking to primary care. And we would have people who would die of medical reasons at age 40, 50, heart attacks, heart disease. And the people really, there was just no comprehensive care, coordination, no accountability for quality in these areas. And these are the things that are now in the forefront that we're looking at. Because right now, the way our system is, it looks like those little silos. We have primary care, mental health, substance use disorders, and nobody talks to each other. It was so interesting, I was saying this morning, I have a lot of experience in the mental health and substance use disorder field. I have no experience in the DD field. And when you were talking, I didn't even know the acronyms you were talking about, and I have been working for over 30 years. And that's kind of pathetic. I'm a licensed social worker, you would think I might know. And if I whip out my acronyms now, you're not going to know them. And so we don't talk to each other. And I think that's how we got into the snit we're in. And that is what has to stop changing. So one of the things that happened while this was all going on is we knew that we were going to be managed. It wasn't even worth fighting that. We had the illustrious Wisconsin person come over and be in charge of Medicaid. We knew that managed Medicaid was on its way. It sort of had been sinking, slinking into all the counties anyway. And in order to counter the state efforts to throw us directly into managed care, Harvey, our executive director, and 41 other member and advocacy groups got together and really said, give us a chance to have behavioral health organizations first, because we need to learn how to be managed, because right now we're going to go under if we just go directly into managed care. And actually, they allowed that. And so, in January, I guess, we got these 5 regional behavioral health organizations. Yours is the New York Care Coordination Program with Beacon Health. And the job of these BHOs, our BHOs, was to just really take care of inpatient care and emergency care. That's it. Monitor hospital days, try to reduce them. We're not in outpatient care yet. They want to reduce readmissions to the medical side, and they're trying really hard to be able to get people to talk to each other, to have like robust networks of people who are referring to each other and kind of be on top of things. And this last one, profile provider performance, I'm like so stupid, I was like, what's that? But that's just tell everybody how everybody else is doing. So, you know, we hate seeing our name, and OMH started doing that by posting your certifications on the web, and all of a sudden everybody was like, oh boy, I better get 3 years, because I don't want my 6 months up there for everybody to see. So one of the things that LCSW-R DHO is to profile provider performance and to really try to incentivize people to do better. And this is kind of a stopgap because it's giving us 2 years to learn how to provide cost-effective quality treatment. And from that, in 2014, we're going to be in a fully capitated fully capitated managed care system. And what that looks like is beyond anybody. This is, I actually was at the health department last week on Wednesday talking to some people from Washington who are doing like an audit of all the states that have health homes. And I was talking to the assistant director there, and she was saying to me, this is just a moving target. And it's true. Right now on the mental health side, and you didn't start your DD stuff yet here in New York, did we? With health homes, and where mental health, behavioral health is the first. Yeah, that's what I thought. So, you know, we're just in it. It's like, who said this morning about, did you say building a 747 and flying it at the same time? You did. It's kind of like that. So these health homes are up and running. We're going to talk about them. The behavioral health organizations are up and running. 2014 is around the corner, I'm sorry to say. And we are going to be in fully capitated states. So, so the future is kind of interesting for us, and it's full of a lot of change. I wanted to take just 2 seconds to talk about the Medicaid redesign team, because Jason did something very good here in New York. I don't know if he did the same in Wisconsin. He formed this Medicaid redesign team, and on it were tons of advocates, and it broke into all kinds of work groups. And all the, you know, the biggest mouths and the smartest brains of the state, you know, were interacting on these work groups. Harvey was on a couple of them. And they came up, each work group, and I should know this, but I don't remember how many work groups there were, but there were quite, not 1 or 2, there were quite a few of them. And each one of them had, you know, 15, 20 people on it, and each one of them came out with 80, 90 recommendations. And then they pulled out a bunch of those recommendations to actually institute or to really focus on. These were the key provider outcomes for the mental health, the behavioral health work group. So it was really kind of targeting what is it that's most important in the provision of services, and I'm not going to read them, you can see what they are. You know, this reduction in use of court-ordered outpatient treatment is a huge deal on the mental health side. You know, this is for another discussion, but assisted outpatient treatment is, you know, is court-mandated services for people who haven't done anything yet. So it becomes a huge balancing act between human rights violations, mental health treatment, social control, responsibility, and it doesn't always work in the mental health side of things. So we really talk a lot about that. But you know, you can see what we're looking for is proper services that really listen to people and offer what people need. The final recommendations, they talked about the savings, and there has already been savings because of all those readmissions. Some of the savings you talked about were from reduced rates and less services. Here, I have to say that on the behavioral health side, we just really have too many services. I mean, I've been a provider for years, and people are just serviced to death. And savings from some of those unnecessary services really are, one of the recommendations was, let's reinvest that in appropriate community care. There also was a recommendation, this is the other thing in New York that is like the elephant in the middle of the room, no one ever talks about it, but I have to say, after running an agency in one of the most conservative counties in the state of New York, it's very freeing to work for NYAPRS because I can really say whatever I feel, which I didn't used to be able to do since the county exec was always like right over there, kind of looking over my shoulder, and I didn't want to lose the money he gave us. But we have a huge state psychiatric system in this state. We still have 13 or 14 state hospitals, and they all have extensive outpatient treatment. And they are not in the mix. Only we nonprofits are in the mix. So one of the recommendations was, let's throw the state psychiatric facilities in the mix and just make sure that they're kept to the same standard as everyone else. Some of them provide fabulous care. Others, you know, like anything else, like the nonprofit sector or the for-profit sector, some are great, some are not, but they're not monitored through the system. So there was a recommendation to do that. And then the other thing was that, you know, aside from employment, the other issue that, and we all know this, you provide fabulous housing, people don't have stable housing. When they don't have stable housing, then they can't work on the other issues of their life. So that was the other recommendation, was to toss some money into you know, increasing our ability to provide some stable housing for people and models that work. The MRT also saw that peer services were extremely important, and they saw that you know, we had something called a chronic illness demonstration project in this state. It was mostly in New York City, and it was sort of a precursor to what a health home looks like, and it had a lot of peer services. Actually, NYAPRS provided peer services through that project, and the rates of readmission, the rates of use of ER plummeted by peers going out and locating people and making relationships with them and helping them to connect to services. So there was a lot of value of peer services in the MRT, and really a lot of talk about trying to incorporate them into health homes. Now I have to tell you, now that health homes are up, there really is no mechanism to pay for peer services except for, you heard this morning a lot about the PM rate. If the health homes do a good job with what they're supposed to do, there's money left over there to buy peer services, but it isn't mandated anywhere. And you know, there's a lot of talk given to its usefulness, but we'll see what happens as time goes on. And then we have this, was mentioned this morning, aside from all this financial pressure, we have this additional legal pressure, which is the Homestead Act, where you know, people need to be served in the least restrictive environment, and it is really kind of being pumped up by Governor Cuomo. So we have these Olmstead legal pressures on providing appropriate service. We have financial pressures. And one of the things I learned when I was trained in psychiatric rehabilitation is that nobody changes unless there's some kind of dissatisfaction. You gotta not like where you are in order to go somewhere else. But it doesn't have to be internal dissatisfaction. It can be external dissatisfaction. And we've seen through our system, well, if you've been in and around as long as I have, you often see that the external dissatisfaction sometimes drives things in a more strong way than the internal dissatisfaction. So that's what we have. We're broke. There's a whole financial issue. People are dying 25 years later. People have the highest unemployment and poverty rates. And we have Olmstead saying, what are you doing, New York? You cannot have this. So there's all this pressure coming to bear on us to provide something different. So it's kind of like the perfect storm time. So if we just look at the financial and we just save money, we're going to wind up in the same place that you suggested around your presentation. We're going to wind up in a place where money goes down, but services goes down, and maybe quality goes down. We don't want that. We don't want to just divert people from services. What we want to do is be more responsive to people and help people get the kinds of supports that they need to have a satisfying life. So in a way, the pressures are outside of our system, but it falls on us as people who utilize services and people who provide services and people who manage services. We have a golden opportunity right now to be able to create something that has these ends in sight and yet provides the kind of services that give people back an opportunity to have their life back. Or, on the other hand, because I'm a good Gemini, so I get to see every side of every coin, are we going to go back to the medical model? You know, we all want to integrate. I just spent 15 minutes talking about that. But when I came out of social work school, it was all about maintenance and schizophrenic mothers and all kinds of stuff that when I think of now, I want to reel. And we fought for rehabilitation and recovery, and now our mental health services could be back in medical facilities. Will they be integrated or will they be taken over? And I think, again, it behooves us to make sure that what we've done so far, the good things we've done, don't get lost as we move over into this new integrated system. And any way that we do it, anybody who thinks we're not changing, you're deluding yourself. We're already there. It's a moving train. It's not stopping. Now, New York has another way they do things here. Any of you who've been around as long as me, you know all the initiatives. The Blueprint for Change, the Winds of Change, the SNPs, that they come, they go. There's always some large political group that gets up in arms and stops it. When we started PROS, the PROS program, everyone in New York City said to me, it'll never happen, because that's what happens. Things start, they end, but this one's not ending. I'm going to tell you right now, this one's not ending. We're going there. There is no way on earth this is getting derailed. Mostly because there's no money. And those of you who are in the accounting side of things, as a CEO, I had the joy of dabbling with all of that. We have been balancing the New York State budget like with a little accounting book, with an accounting software package. There's actually no money there. It's just moving things all over the place. The mental health system's been cut for years. And all of this money that we get is just moving around money. So, the stuff that's driving it now isn't going to stop. And whatever we do, we're going to have to respond to what's going on in order to survive. So, for me, that little kid with her hands, I thought that was so cute. Is it something good, is it something bad? We could sit back and we can whine and bellyache, we're very good at that. I'm very good at that. I love to complain about anything. I told you I'm from New York City, it's sort of culturally in line. I'm a Jewish girl from the Bronx. I like to whine, it makes it better, makes me feel better. But the truth is, it's really a time of opportunity because it's happening to us, and now's the time to figure out whether you're going to have it happen to you or whether you're going to drive the bus. And that's where we are right now in mental health. So we're on the cusp of the second biggest wave. I think the first one was the institutionalization before a number of you guys were born, before I was in social work. And now we're in this big managed care, push. And there's been a lot of complaining about it. But again, I think we need to understand it, and we need to see how we can use it to our best interest in helping people get what they need. This was really talked about before, so I'm not going to kind of spend a ton of time when my previous presenters discussed some of this. It's sort of, Dale Jarvis is the one who told me I have to put pictures on my slides. He did this great piece, and it's sort of the overlook, it's the overlay of where we're going. The AAA you keep talking about, and that's really just better health, better quality, less cost. Improve the health of the population, not just the individual. And how are we going to do this? We're looking for reduced errors and waste in inpatient. We're looking for person-centered health care homes, and all of these things in the middle that are going to help get us there. You have this in your packet, so it's just kind of a nice little piece. And Mike Hogan has made a lot of statements lately, and they're kind of interesting. And, you know, just because he's commissioner of New York State doesn't mean he knows any more than any of the rest of us, you know. So we called it his crystal ball. And here's a few things he said. The worry is, like I said before, that if we move over into the physical health system, and don't think that is impossible. You know, do you have a federally qualified health center up here? FQHCs?
Just one of the process of.
You're trying to become one.
And there's one already.
Oh, there's one already. FQHCs, by their very charters, or whatever they're called, their regulations, need to provide behavioral health care. They don't provide it at the level that behavioral health organizations do, but they could. And they could really take over a number of those services. Most of the recovery and rehab services would probably drop out because they're not funded under FQHCs. So we need to watch that moving over into the mainstream. Because in the general health sector, you know, with us out of the picture, we don't really think that behavioral health is going to be properly taken care of. We also need to really integrate medical care into our mental health specialty settings, which we're starting to do. You know, you guys have a great system here. I was having dinner with Paul last night, and I was really, really impressed with what you do at the Resource Center. Because you have all these pieces of people's lives, and you do integrate them, and you have them available for people. But, you know, in Putnam County, where I was, my agency provided substance use and mental health treatment and a PROS program. No housing, no vocational, okay, and no medical. And there was nothing else there. We were only nonprofit. There was a little state facility and then some private for-profit chemical dependency programs and a hospital. And the hospital had some clinics, but there wasn't a lot of interaction. And if someone got sick in our agency, there were a few people, doctors who would take Medicaid, but there were no specialty doctors. If someone got cancer or heart disease, we had to transport them 40 minutes away to Westchester Medical Center. So we in a lot of places, we don't have this integration of behavioral health and physical health that you have here. So, you know, I was just to say to my guys in Putnam County, don't think of this. We have a recovery-oriented agency, everybody else does. You know, you get kind of caught up in where you are. I get to travel all over the state and really see what is and what isn't. And we are all over the place in New York State. Some things are terrific, some things are, you know, from the dark ages. And what you have here is very special. There aren't a lot of agencies that have such an integration of services. So you should know that that's special and work hard to keep it because it's a very important thing. Also, Mike Hogan has talked a lot about leadership, and I think you're going to give a chat about being entrepreneurial, and there's been comments made already today. This is not what it used to be. We can't put our heads in the sand and provide services anymore. We need to have new partnerships, new networks. You know, we're kind of crawling into bed with new people. Some of them we're going to like, some of them we're not going to like. And we need to find a way to have that. And the other thing is that CEOs of behavioral health organizations are often really terrific clinicians who move up. And very often those people don't have a management background. They don't understand finances or business plans. And that's something that we need to learn. We need to, you know, when you are a CEO of an organization, the buck stops with you. If your CFO makes a big mistake, it's your head who rolls. You're the one who goes to jail. You know, when your charts aren't done right, those of you who are direct service people, and Medicaid comes in, does an audit, if there's something fraudulent in there, it's Paul in the orange jumpsuit. So, you know, we need to learn as CEOs. Do you look like Paul? I look terrible in orange, and these stripes don't go with me. So when I run an agency, I like it to be clean, you know? Orange is not my color. But what we need to do is really have a business plan for success. in an integrated way in our programs. And those people who are entrepreneurial, and this was said also this morning, those people who are ahead of the curve, who are inventive and innovative, those are the agencies that are going to flourish. Those are the services that are going to flourish. People always say to me when I go and do TA, I don't understand why nobody comes here. Well, do you go to places that don't meet your needs? Where do you know, if somebody is meeting your needs, if you go to somewhere and they're really giving you what you want, don't you come back? So it really, we're at a point, this crisis is bringing us to a point where we need to really look at what we're doing, listen to the people who come through our doors and provide what they want so that they can have a life. If that happens, the money follows. It's as simple as that. And I think that this is something new for us because we've always just been paid. OMH gives us the money, we get it, whatever we provide, and we move on. And it just is not that way anymore. Where am I? Half hour now? Perfect, that's right in the middle. Look at that. So, Brave New World. What's the Brave New World? Here we go. It's the health homes. I stole this picture from the Department of Health, and I forgot at 10 o'clock at night to write stolen from the Department of Health. So I want to write down that I just love their little picture, and so I put it on here. And when I get home, I'm going to say borrowed from New York State DOH, so I just want to let you know that. So I want to take now, 5-10 minutes to tell you about health homes. How many of you really know what health homes are? Be honest. Okay, NYAPRS is providing, actually you guys are in it, care management training, care coordination training for case managers who are moving over into care coordination. And we did this assessment. There's 700 people statewide and 200 in Long Island. So 900 people are being trained right now. We did this assessment. And of this assessment, we asked things like, how many people know about health homes? 80-something% of the people did not know. They didn't know what their job would be in a health home. They didn't understand what a health home was. And these are the people who are becoming care coordinators. So the training is really important, which is great. So I'm going to spend a little bit of time describing kind of what a health home does. So what it is it's a multidisciplinary team of people. And it's kind of like, think of it, I think someone said this morning, like a hub with spokes on a wheel. So the health home itself is responsible for only a few things, which I'll talk about in a minute. But it creates a whole team of people, and you guys are not the health home, but you're going to be one of the spokes, or a lot of spokes in the wheel of the health home up here. And those, those are great things to be. And those who are in the spokes will get paid for now the old way. But the people who are the health home, responsible for the health home, will be paid in that per member per month way. So the network leader, the person who is at risk in the health home, they can either directly provide or subcontract for the care that's given. And the Department of Health prefers that they subcontract. If they see a health home who's providing all the care themselves, they're not very happy about that. So the push is to really subcontract to provide that care. The health home remains responsible for all the health home requirements and even something that the subcontractor does. So here's one of those things that's a golden opportunity. Right now, for 2 years, all OMH and OASIS licensed case managers are giving care coordination services. And they're getting paid a very strange way. First their old way, then this year it's supposed to be half through OMH and half through the managed care plan, and then next year totally through the health home. But the point is, you can't fire the OMH OASIS case manager for 3 years, all right? After 3 years, the health home could provide the care coordination themselves or contract with somebody else to provide the care coordination. So we have 3 years to prove that we can do this job better than anybody else can. And I'm not sure everybody realizes that, because a year's over already, almost over. So this is one of the ways we're being eased in. Health homes coordinate services to the network partners. The network partners continue to bill Medicaid. So the health home gets a per member per month rate. It has to purchase, hang on a minute, didn't I say what it has to, here, okay. It has to do these things, these 6 things, and it has to either do them or purchase them. So it has to be involved with care management, outreach and engagement. They get lists of people from Fidelis. We'll give them a list of people, not Fidelis. Who's your, that's a BH, that's a managed care. Who's some regular managed care company you might have up here? I'm not sure who it would be. We have GHI or AmeriCares or any of those kinds of places. And they give you a list of people who are the highest users of service, of claims data. And you have to go find them. This is the primary thing the health home has to do. Then it has to coordinate care, make sure that people are getting what they need. It needs to do comprehensive transitional care, making sure people go to all those folks on the network. It has to provide individual and family support and make sure that people are getting what they need referral-wise, and it has to have all this technology being connected to, all these folks have to talk to each other. So this is what the PM rate pays for. And they either can pay for it themselves, provide it themselves, or they can pay for it. And what are they supposed to be doing? They're supposed to be minimizing the silo effect. They're making sure that people have a choice to do what they want. They need to meet quality measures. The Department of Health does not care about how many times you see someone or how many times they come in or where they go. They want to see if they're getting a life. Unfortunately, right now, the measures, and if you go on the DOH website, it's very full. It'll tell you what the metrics are, but they're all about medicine right now. Take, the medication adherence, reduction of ERs, reduction of avoidable hospitalizations. NYAPRS been fighting with them, and they really have agreed that it's necessary that we add functionality in there. That, that people have a stable apartment, that they have a good job, that, that they're reconnected to family, that they have friends, that they're marrying, having children, having a life. And eventually those kinds of outcomes will come. And then one of the things that we had a really interesting webinar. NYAPRS also does, I do a health home learning collaborative that you guys are great, you're NYAPRS members and you join all of our things, which is wonderful. But I do a webinar series for what we need to know for health homes, and we had Dr. Joe Parks, who's from Missouri, and one of those M states. I blocked for a minute. And they have health home already instituted, and he presented what he was doing. And I asked him what he was doing about cultural competence, and he said the cultural competence they had in Missouri was just having medical and behavioral people talk to each other. They weren't yet doing anything about cultural competence. I don't know what the population is in Missouri, but I know in New York State we're incredibly diverse. And if we don't address cultural competence, then we're not going to be successful in this. And it has to be linguistic and cultural competence. We have everything from large urban areas to small rural areas to reservations, and we need to be able to be aware of that. So in here are a few things that I think we need to be culturally competent. And I just love this last line, which I also stole from someone at NYCCP. And it says, it's more important to know what sort of a patient has a disease than what sort of a disease a patient has. And I think that's really important. It's like, who is the human being standing in front of you? What makes up their nature? What culturally do they come from? What shape their thoughts and belief systems and values? And how can we tap into that to help them to get what they need to really have a clear life? So one of the linchpins in this is care coordination. Let me just take when do I have to start? 2:15? Yeah. And so I want to talk a little bit about that. Care coordination is different than case management. And the reason it's different is that it really, it does a whole number of different tasks. And here we have some similarities and some differences. Do I have any case managers in the room? No case managers?
Care coordinators.
Oh, care coordinators, okay. Case managers traditionally have provided the most wonderful services. And all the skills that you developed as a case manager are all useful in care coordination. You just need to add to that. You need to add those skills of engagement and assessment and referral and advocacy and linkage to all of those services. You need to add all this increased knowledge about integration of services and physical health and substance use. And also we need to concentrate much more on outcomes rather than on process. And this one as well just gives you a little bit of feel about all the skills that your case managers currently have and how they can be moved into care coordination. The most important thing here really is that, that the care coordinator is a central part of the health home team. And we so, you know, in mental health and behavioral health we have statuses, let's face it. You know, in social work we have statuses. I went to Hunter in the city and case work was the highest, that's individual psychotherapy. Then I was a group worker and an administrator. I had a double method. Administration was just over there, that's the enemy. Group work was under case work. Community organization was under that. You know, and you know, if you work in a methadone program, that's kind of on the bottom. And you know, case management's pretty low down on the status pole. And I guess what I'm saying is, it's pretty high up on importance. And care coordination and case management is the center of changing our system. And I don't think we can underestimate how important that is, that we really nurture our care coordinators and we make sure that they're armed with all the information and skills that they need to be able to produce the outcomes that are going to show the field that behavioral health deserves to be at the center of it and doesn't deserve to be pushed outside. All right, so what do we need to be ready for the future, okay? This is what public mental health services ought to be. What do you think? Anybody have an argument with me? It's like mom and apple pie. I mean, come on, you know? And this is actually what people want from the mental health system. When I have time to do an interactive workshop, I'll say to people, what do you think people want from the mental health system? And people say, you know, what?
Apple pie.
Apple pie, absolutely. But people say, you know, appointments on Saturday and more groups and more trips. It's not true. People don't want another medicine. People don't want another psychotherapy appointment. People want the same thing that we all want. They want a better place to live, a stable place to live. People want to go to school. Look at the panel we heard today. What do people want? A job, school, supportive relationships. They want help in time of crisis in the amount that they want, when they want it. And they want an opportunity for recovery. There are 1 million definitions of recovery. 1 million. I like this one because it talks about developing new meaning and purpose as one grows beyond the effects of mental illness. You know, we all have everything. If I asked everyone around this room, you know, do any of you struggle with any particular issue? Oh, 3/4 of you, if not more, would be struggling with some issue. But yet we're all here, we're all dressed nicely, we're listening to me drone on for an hour, and we're smiling, we're laughing at the appropriate places. We're moving past whatever it is that we're dealing with to be able to have a full life. And that's what people in the behavioral health system want. They don't want maintenance, they don't want to be medicated to not be able to function. And yet, is that what our service system gives them? And when I started this talk, and I said, I'm not sure we've been so successful all these years, this is what I meant. We haven't hurt anybody. We haven't, we're not abusing people in general, we're all working really hard. But are we offering people opportunities for a life outside of services? That's the question. And I can answer for me up until the late 80s when I had an epiphany and began to switch over to recovery-based services after hearing a consumer advocate, Patricia Deegan, and Bill Anthony, the head of the Center for Psych Rehab at Boston University. They stood up on a stage like me, they said the simplest thing, and you could have bowled me over with a feather. They said, people with mental illness, they want and deserve the same things in life as everybody else, and they can have it. And I was just floored by that comment. So many years later, we're not so floored by that comment because we've moved in those directions. But that was the beginning of the changeover, and there are many places that have not moved totally into understanding this. In our new healthcare system, if you provide services where people feel empowered to take back their life, where people can give up benefits and get a job, where people are housed stably in a place they love, where people are getting to keep their children and have families. And as the commissioner in Putnam County said, everyone deserves to marry and be as miserable as the rest of us. So I always think about that when I go on this tirade, but it really makes me laugh. If you're doing that, then you're going to have good outcomes and you're going to have the right kind of money. So I just want to leave you as I wrap up with a couple of things that are really near and dear to my heart, which is to really look at yourself and your practice without telling anybody else, without raising your hand, without anything else. But when you walk out of here and you manage your programs, when you interact with the people that you provide services for, when you design your policies and procedures in this agency, when you write your job descriptions, when you choose to hire people, all of those things, do they believe that recovery is possible? Recovery can occur with our intervention, without our intervention, and despite our intervention. And it is much more than symptom reduction. It even can occur when symptoms reoccur. One of my trainers was doing a training on employment, and she said she was afraid to go back to work because she still had symptoms. And she went back to work anyway, and she realized after a year that she didn't have symptoms anymore. She'd forgotten all about them because work made her forget them. Recovery is individualized. You're going to be different than you, you're going to be different than you, you're going to be different than you. Because people are different and they're interesting, and that's why we work in this field. And there's no one homogenized way to deal with people. And it occurs in the presence of someone who believes in and stands by the person. What do you think the single most important thing to someone's recovery is? Just shout it out. Come on, are you all like heat struck? What helps somebody recover the most? A friend? Hope, belief? Acceptance? I'm going to tell you what studies have shown. When a worker believes that the person can recover, that's the single strongest thing that pushes somebody's recovery. So when I used to run a crisis team in Westchester County, I used to say, those of you who do crisis, we do not have the power of life and death over people. When people want to commit suicide, they do. But we do have this power over people. Isn't it fascinating? We have the power of recovery over people. Because if we don't believe in them, then they don't believe in themselves. So I find that to be a very interesting piece. And recovery from the consequences of the illness is sometimes more difficult than the illness itself. And by that I'm talking about the unemployment, the stigma, the poverty, the loss of family. So we have challenges for peers. Here they are. It's a brave new world. It's a scary place. Peers need to do all of these kinds of things, know their rights, get ready to take risks, strengthen their own stamina, have and find faith, explore alternative ways of healing outside of our system. These are all things that we need to support people when they are going through their own recovery. For providers, we got our own challenges. There's training, and then more training. And then sustaining. Training is often about philosophy, and then there's staff competencies. You can believe something, doesn't mean you know how to do it. I used to play music a lot, and I played the guitar, and I remember I took piano lessons as an adult. I really wanted to play the piano. I was so bad, and it's like I just go home and play the guitar again, because I was so good at that. And I just could not move that ability from one place to the other. And so these are important things, that just because you want to do something, you believe you can do it, or you're good at something else, doesn't mean you can generalize it elsewhere. So we need to really train staff in competencies. Things like outreach and engagement. Do you know that people don't know how to reach out to someone? I mean, Michelle and I were talking about this morning around agencies that can't get people to come in. Some of it is we just don't know how. And we don't know how to listen. We don't know how to truly listen. So these are all things that are important. And the last one, what did we just talk about? Get entrepreneurial. We got a whole lot of new partners and new payers, and we have to think outside the box. My own program said to me, when the PROS numbers went down from 110 to 70, they said, well, we're getting everybody healthy and they're getting out of here, and now there's nobody left. And I said, well, find new populations. There must be somebody who could, need some help and get a life. How are you marketing this? Are you marketing it in jargon, or are you saying, are you lonely? Do you want a date? Do you want to have a baby? Do you want a job? Do you live in a place you like? I can help you get that. So, so think outside the box and create that recovery vision. Believe that recovery is possible. Really believe it. Help people uncover their hopes and dreams. When I ran a day treatment program, the first thing we asked in intake was not how many hospitalizations have you had, what medications were you on. It was, what are your hopes and dreams for your life? Do you know people would break down in tears? No one had ever asked them that question. I find that pathetic. And how can we expect to function in this brave new world as a leader if we can't even ask the people who come to us what their hopes and dreams are? Because our mental health system has spent a long time battering the hopes and dreams out of people by having them be good patients. And that's not where we want to go. That's not where you guys go with the services you offer. But there still are places where that happens. And that's something that we can't present to an integrated arena. We can't go to a bunch of medical people and substance use people and say, well, here's a person with no hopes and dreams, they're going to live in the mental health system their whole life. We're not leaders if we do that. And so, assure that people can reclaim meaningful life and roles, because that's really what's important. In all this to-do about change and integration and health homes and accountable care, there's so much information. I can't keep track of it myself, and this is my job now. I'm not doing it part-time anymore. It's my job to keep track of this, and I can't. But in all of that that's going on, we can't lose sight of why we're in this. And that's why I'm going to leave you with this. Because why did we go into this field? Did we go in to make money? Yeah, right. I don't think so. I'd be the CEO of IBM. I'd be rich now. We didn't go in to make money. We went in it because we wanted to make a place that was better for humanity. And most often, we wanted to create a better life for people than we had ourselves. That's really what motivates a lot of people to go into this field as practitioners. And so, as we go on, as we move up into management, I know there's a lot of you here who are managers, and I moved up from clinical work to management too. But as we move up, and as we move out, and as we get totally entwined in state rules and federal rules, and what other states are doing, and in acronyms we don't know, we can't lose sight of the vision. We can't lose sight of why we came in. And I love this quote because, especially in the end, the vision begets not false promises, but a passion for what we're doing. Because you're all in this for a passion. It's very obvious to me that this is an agency with a passion. And so if you hold on to that passion, and you remember what you went into the field for, all this stuff swirling around us will not be peril. It'll all be possibility. Because the end result is the brass ring. And what's the brass ring? It's somebody who can sit up here and say to you, I have a life now, and you help me get it. So thank you for having me. Good luck to everyone. I know you're going to be
We're going to take a 15-minute break and come back at 2:30.